Bonjour and hello. Thank you for connecting with us today over the next few hours. My name is Marianne Comperet and I'm speaking from the International Society for Neglected Tropical Diseases. And along with Médecins Sans Frontières, a wide array of partners, medical professionals, researchers, advocates, and most importantly, survivors and their voices, we will be shining the light today on the highly neglected disease Noma, a disease that shouldn't exist anymore. We're truly delighted to welcome you today, along with colleagues tuning in from around the world. And I'd like to take this opportunity to salute those participating from Nigeria, Singapore, Canada, Pakistan, Norway, Brazil, Sierra Leone, Thailand, and many, many more, which sadly I can't all mention here, but very warmly greet and thank you all for joining today. And so before we even begin, we can already celebrate as a community this one major achievement. All of us here today, we have highlighted across the world the mere existence of Noma as a priority public health issue. It's not uncommon to hear of even highly experienced public health professionals who will say that very sadly, they had never heard of Noma. In fact, if I type the word Noma, even my computer will remind me this surely can only be a spelling mistake. After all, what can the word Noma possibly mean? So let's take some time today to come together and change this. And despite the ongoing tragedy that Noma continues to be, we launch this meeting with much hope and with a cohesion of many voices, loud and clear, that advocacy for Noma and affected communities is now sharply on the rise. And once again, we thank you for being here and adding your voice to this. We hope you will enjoy the meeting, and on a practical level, this conference platform. You will have the opportunity to hear in this area firsthand stories from survivors, presentations on ongoing research, collaborations, but also remaining gaps in the treatments and prevention of Noma, and very importantly, some strong calls to action. You'll also be able to join in Q&A sessions, and we really want these to be highly interactive. Our speakers will be there to answer your questions and hear your comments. And so for this, we will move to the sessions room. And as this is a bilingual event in French and English, we'd like to reassure you that these discussions too will be translated in French in the chat box. And so please, throughout, do make use of the many chat functions. Don't forget to introduce not only your name, but also your organization, your country. It's always great to see the diversity of participants. And finally, let's also make some noise across social media. So if you are tweeting, please use the hashtags #ZeroNoma and #BeatNTDs. So now, without any further delay, let's place Noma center stage. Many of you will be very familiar with the disease and its devastating impact, but perhaps some of you haven't yet come across Noma very much. And so to tell the story of Noma, let's begin with a very short film created by the award-winning filmmakers Claire Gentet and Fabrice Cantarini from Inediz, a short film officially selected last year at the Health for All Festival, organized by the World Health Organization. And so let's find out what it's like to be surviving Noma.
Ina kwance lokacin ina kamar zazzabi, yana jin na hiya kumbura duka. In sa hannu na hina jin din yayi laushi. Sai nake kuka. Ina kuka ina kwance ni ne kada a zaure ko da sa hannu in ji ya tsure.
Noma is a gangrenous infection of the face, which usually starts from the gum or the gingiva to the fleshy parts of the face. It destructs the bones, the soft tissue, and everything around the face. It affects children at the age of 2 to 7 years old, but usually from 2 to 4. It can affect anywhere on the face, mainly on the sides. And there is also a central noma which affects the nose and the upper lip or the lower lip.
No kaga da rawanin da ko da ni tashi da rawanin gani da ni wayo rawanin ga kullu irin ina tare da wannan rawani ina rube fuskana. To sai ni hita can wani kaya ni zabo ko Allah ya bani wallahi.
Na shekara ko ina tare da su. To ka gani don mata na biyu yayi duk sun ka jahai. Yan kayo ni aka ce ko ni ai kila tahiya ni kai don ba mu so ne. Ce to ni mutuwa dai ka sa ni in tahi in bari.
Noma patients really have that stigma whenever they get into the society. It's hard for them to, integrate into the society because of the disfigurement on the face. And they also have a lot of difficulties while eating, while feeding, because if half of the face is down, is gone, is eaten by Noma, you'll find out that patients, have to do some maneuvers for them to get food into their mouth and then to swallow. And part of the problems they are facing is a speech problem.
When somebody is like that, definitely there will be intimidation between you and people.
Ni da wannan ciwon ya hana ni abu da dama. Gaskiya wannan ƙarami abu da dama tana hana da na iya shiga cikin jama'a in zauna. Kuma haka da na iya wannan. Haka kana yawo haka a cikin gari. Da sosai da.
No one came to this hospital and go back remaining the same. Because the way they come, they will go back different. Since the operation was done, I'm so happy. I can go to anywhere. I can stand with people at anywhere. I felt I'm a human being like others. To anybody that is in my condition like this, they should not feel bad and they should not lose hope.
No doubt you'll all join me in applauding this film as a very sobering and moving account of Noma, with such a delicate balance between documenting the disease and telling the story of the patients and the many communities involved. 4.5 very small minutes, but with very big reach in terms of highlighting the neglect both of the disease and those communities involved. And this film very much echoes the many voices working in the field of Noma, but also in a wider sense, all the neglected diseases of poverty. So I'd like to turn now to our speakers, who will delve with us a little more into what Noma is and its characteristics, a large part of which unfortunately remains its widespread neglect, but also what is needed, as well as what is already underway to tackle the remaining gaps in the understanding and control of Noma and to overcome this neglect. In this first segment, we will hear Fidel's story. Fidel Strub, Noma survivor and advocate, is now president of Noma Aid Switzerland. We'll also hear Dr. Denise Barati-Meyer outline what we do know and what we don't know about Noma as principal member of the Noma Project Research Group. But first, I would like to welcome Professor Peter Hotez, Dean of the National School of Tropical Diseases at the Baylor College of Medicine in Texas, and editor-in-chief of the PLOS NTD's journal. PLOS NTD's recently added NOMA onto its own list of neglected tropical diseases. And so I now hand over to Peter and our speakers to highlight the needs of NOMA as a neglected disease.
Hello, I'm Peter Hotez, and it's my honor and privilege to welcome you to this very important summit on NOMA. NOMA is an illness that does not get a lot of attention, but it's a very important and unfortunately highly prevalent neglected tropical disease, particularly affecting children who suffer underlying malnourishment because of they live in extreme poverty. And it has the impact of not only because of its health effects, but it's a horribly socially stigmatizing disease as well. You know, it's not easy to point attention to NOMA, especially in this time of COVID-19 when everyone is so focused on that illness, including our efforts to develop a COVID-19 vaccine. But the truth is, important neglected tropical diseases like NOMA haven't gone away. In fact, they've probably even worsened due to the poverty and neglect that's happened in this time of COVID-19. So I congratulate the leaders of this summit for organizing this. It's extremely important. Right now, NOMA is not recognized on the list of neglected tropical diseases by the World Health Organization, those 20 illnesses. We certainly recognize it at PLOS neglected tropical diseases. I think everybody, including the World Health Organization, however, is fully on board with recognizing its importance and the need to develop new innovative diagnostics and treatments and preventive measures. And these kinds of summits are so important because they do elevate the global attention for conditions like NOMA. And I think summits like this really deserve our greatest attention and our highest priority. So thanks so much and good luck on the summit.
Hello, everyone. My name is Fidel, and I'm really glad to be here with you, with all of you. And it is a great honor for me to be part of this. And it is quite important for me, and not only for me, also for other affected people which had the disease NOMA like me. As you can see, I'm one of the affected, also the lucky one who had the chance to be adopted and to live in Switzerland. I was diagnosed in 1994 with NOMA, and I was sent to the Centre Persis Valley in Waiguya, and I was treated by Dr. Salah. He fought for me for about 2 weeks. He didn't think I would make it at all as he saw me. I was only skin and bones. There was no muscles left, literally. And he fought hard to stabilize me. So I was sent then to Geneva, where Dr. Brigitte Pittet was assistant on me with my future mother. She was also there. And yeah, this is how I came to Switzerland. And now I'm living here in Switzerland alone in my nice apartment. And I became recently president of the organization NoMa Hilfe Schweiz. So I had now about 27 operations in my lifetime, and quite difficult ones too. 6 years of logopedy just until I could speak like this, 6 years, every day, 15 minutes in the morning after waking up, and in the evening before going to bed, like with ooh, and moving the lips and everything. It takes a toll physically and psychologically on children and also adults which get sick with this. And it is important to be one of the beacons of hope for those who are affected. And also, I want to give other organizations the insight how it is to be affected with Noma and how it affected everyday life. What I want to say to all of you who are present in this meeting is, again, thank you very much for your effort and for fighting this disease. Without all of you and also with Dr. Pika, who started about 1993 around with the campaign to look for this disease, I would be dead, that's for sure. So, and I'm really grateful that you do this, and it is important that we fight this disease because it has no future here. It should be eradicated. And my message is spread the word, tell the people what it is, even if it is sometimes hard to digest, how ugly it can get. And we cannot allow in this time especially to have this kind of disease, which is so easily treatable with simple measurement, hygiene recommendation and so on, that this disease still exists. And we need to stop this. And with your help and collaboration, I hope we can do this in near future.
Bonjour à tous, j'ai l'immense plaisir d'être ici avec vous aujourd'hui pour vous parler de ce que l'on sait et de ce que l'on ne sait pas encore sur cette maladie négligée qu'est le Noma. En effet, malgré le fait que le Noma soit présent depuis toujours, il avait été décrit en premier par Hippocrate en Antiquité, puis décrit très souvent tout au cours des siècles, jusqu'au siècle dernier, où il y a eu des cas de Noma encore en Occident, en Europe ou en Amérique du Nord. Eh bien, malgré cela, il y a encore plein de questions, beaucoup de questions ouvertes pour cette maladie. Ce que l'on sait depuis longtemps, c'est que le Noma est une gangrène qui débute au niveau de la région buccale, mais qui très rapidement, en l'espace de quelques jours, s'étend aux tissus avoisinants du visage. On sait aussi que le Noma frappe de manière prioritaire les enfants en bas âge, entre 2 et 6 ans, surtout aux alentours de 3 ans, et qui présentent déjà un mauvais état général en raison de maladies concomitantes ou d'une malnutrition importante. Le Noma ne détruit pas seulement la peau du visage, mais également les tissus sous-jacents, c'est-à-dire les muscles et les os du visage. Comme vous le voyez sur ces images, le Noma laisse des séquelles esthétiques qui sont extrêmement importantes, mais il laisse aussi des séquelles fonctionnelles. En effet, en fonction des régions du visage qui sont détruites, l'enfant pourra présenter des difficultés pour parler, pour manger, pour avaler, pour respirer et parfois même des difficultés de vision. Ce que l'on oublie souvent de dire, c'est que le Noma a également des conséquences sociales et psychologiques, puisque les enfants qui sont touchés par cette maladie sont stigmatisés, ils sont parfois rejetés par leur société et parfois même par leur propre famille. On les empêche d'aller à l'école parce qu'on a peur de la contagion, alors que la maladie n'est absolument pas contagieuse. Et on a peur d'eux parce que très souvent, dans les régions où ils vivent, la maladie est considérée une maladie causée par des esprits, par un mauvais sort, et on considère que ces enfants portent malheur. Certains d'entre eux vivent perpétuellement cachés, comme la jeune fille que vous avez vue sur les images précédentes. Ce que l'on ne sait pas par contre, c'est pourquoi cette lésion reste limitée à certaines régions précises du visage, comme vous le voyez sur ces différents 4 types de lésions de Noma. En général, le Noma ne dépasse pas le rebord mandibulaire inférieur et ne dépasse pas les cadres orbitaires. Il n'y a rien dans l'anatomie faciale ou dans la vascularisation faciale qui puisse expliquer cette délimitation précise. Autre chose que nous ne savons pas, c'est pourquoi certains enfants, comme Mary sur votre gauche, développent des lésions extrêmement importantes, très destructrices, malgré le fait qu'elle ait pu bénéficier d'un traitement adéquat dès le début. D'autres enfants, comme la jeune fille sur la droite, par contre, ont des lésions toutes petites qui pourront être corrigées facilement avec la chirurgie, et ceci malgré le fait que, contrairement à Mary, elle n'avait pas consulté. Probablement, la réponse est dans le système immunitaire de ces enfants, mais là aussi, on n'a pas d'explication précise. Je vous ai dit que le Noma évolue très très rapidement et j'aime bien vous montrer ici les paroles d'une grand-mère au Niger qui démontre vraiment cette évolution fulgurante. Elle a dit « Ma petite fille est allée se coucher le soir, elle n'allait pas bien. Et le lendemain matin, quand j'ai été la voir, elle n'avait plus de visage. » Le Noma ne commence pas d'emblée avec cette perte de substance. Il évolue à travers différents stades, 5 stades pour la précision. Le premier stade est celui de la gingivite nécrosante. On ne sait pas la durée de ce premier stade puisqu'il est rarissime que les enfants consultent déjà lorsqu'ils n'ont que la gingivite. Suite à cette gingivite se développe le deuxième stade qui est celui de l'œdème facial. C'est un gonflement du visage plus ou moins important. Ce stade 2 ne dure que quelques jours, en général moins d'une semaine. Et c'est le dernier stade auquel on peut encore faire quelque chose pour sauver la vie de l'enfant et son visage. Après le stade 2, la lésion devient irréversible avec le stade 3, caractérisé par une nécrose du visage, le stade 4, qui est un début de cicatrisation après la perte des tissus morts, et finalement le stade 5, celui des séquelles. Il est très important de faire la différence, la séparation entre les 2 premiers stades qui sont complètement réversibles avec un traitement simple d'hydratation, antibiotiques et nutrition, et les 3 derniers stades qui sont complètement irréversibles. La plupart des décès surviennent entre le stade 2 et le stade 3. Donc, ce stade 2 est vraiment crucial pour la prise en charge du Noma. Mais malheureusement, c'est une minorité d'enfants qui consultent durant ces 2 premiers stades. Et ceci pour différentes raisons. Tout d'abord, une ignorance de la part des populations vis-à-vis de cette maladie. Il y a ensuite une banalisation des premiers signes du Noma, qui sont la gingivite et une petite fièvre, et donc les parents ne consulteront pas forcément pour cela. Ensuite, quand la lésion devient plus évidente, eh bien, on a peur de la stigmatisation et on préfère ne pas voir la maladie. On préfère parfois cacher l'enfant plutôt que de chercher de l'aide médicale. Il y a ensuite, bien sûr, des raisons qui sont inhérentes à l'évolution elle-même de la maladie, qui, comme je l'ai dit, est fulgurante, et que même si les parents décident de consulter au moment de l'œdème, le temps qu'ils arrivent à un lieu de consultation médicale, le stade aura évolué probablement en lésion irréversible. Il y a en effet, dans les régions où vivent ces enfants, des difficultés d'accès aux soins qui sont de différents types. Ça peut être d'ordre géographique, d'ordre financier, d'ordre culturel ou simplement un manque d'offres de soins. Et même lorsque ces enfants consultent, eh bien, ils doivent faire face à la méconnaissance de cette maladie de la part des soignants de premier recours. Et ceci, que ce soit des soignants de médecine moderne ou des soignants de médecine traditionnelle. Tous ces facteurs réunis vont faire que le Noma sera diagnostiqué trop tardivement. Et cela va nous mener justement à une mortalité très élevée et à des séquelles irréversibles. Parler de l'évolution fulgurante du Noma m'amène à vous parler brièvement de la cause de la maladie, des hypothèses. En effet, ces nécroses extrêmement rapides sont habituellement d'origine bactérienne. Ce qui fait que déjà au siècle dernier, on a tenté de mettre en évidence les bactéries qui pouvaient expliquer la survenue du Noma. Au début des années 2000, il y a eu quelques tentatives d'isolement de certaines bactéries afin d'identifier un potentiel pathogène. Par contre, des études plus tardives et qui utilisaient des méthodes de séquençage génétique de ces bactéries afin de bien les identifier, eh bien, ces études n'ont pas pu mettre en évidence un pathogène unique du Noma. Ce qu'elles ont montré, c'est qu'il y a plutôt un certain déséquilibre dans la flore bactérienne de ces enfants, déséquilibre qui, lorsqu'il survient en même temps que certains facteurs de risque, va faciliter l'évolution du stade de gingivite au stade de l'œdème. Les études microbiologiques à l'état actuel ne semblent pas vraiment apporter de réponse quant à la cause du Noma. Il y a par contre 2 études relativement récentes qui s'appuient toutes les deux sur un design de type cas témoin, c'est-à-dire qu'on a comparé des cas de NoMA avec des enfants du même âge, mais qui n'avaient pas le NoMA, du même âge et des mêmes régions. Et ces 2 études nous montrent que les facteurs du NoMA, les facteurs de risque du NoMA, sont vraiment des facteurs qui sont liés aux conditions de vie de ces enfants. Et ce sont donc plus des facteurs sociaux que des facteurs microbiologiques. Ces facteurs étaient déjà connus depuis longtemps, mais ces études ont pu les démontrer de manière significative. Et ce sont essentiellement la malnutrition chronique, les familles nombreuses avec des grossesses fréquentes et rapprochées, des maladies intercurrentes telles que la malaria ou la rougeole, et finalement une mauvaise hygiène buccale qui va faciliter la survenue de la gingivite. En fait, tous ces facteurs peuvent être compris en un seul mot, qui est celui de pauvreté. Et c'est en effet dans des conditions de pauvreté extrême que vivent les enfants frappés par le NoMA. Comme me l'a dit il y a quelques années Klaas Mark, qui va vous parler un peu plus tard dans la journée, eh bien, le NoMA n'a pas disparu de l'Occident suite à la découverte des antibiotiques, mais il a disparu lorsque même les plus pauvres avaient suffisamment pour pouvoir nourrir leurs enfants. Tous ces facteurs de risque que nous avons vus peuvent être insérés sur cette spirale qui représente en fait le cercle vicieux du NoMA. Cette spirale débute en son milieu par des grossesses fréquentes et rapprochées des mamans qui sont elles-mêmes sous-nourries, avec par conséquence le développement d'une malnutrition in utero de l'enfant à naître. Cet enfant va présenter un retard de croissance in utero et lorsqu'il naîtra, il aura un bas poids de naissance et un système immunitaire pas tout à fait compétent. Par la suite, en raison de traditions locales, l'enfant ne va pas bénéficier d'un allaitement exclusif, mais il recevra une alimentation en partie inappropriée à son système digestif, ce qui va faciliter la survenue d'infections digestives récurrentes et qui va aggraver l'état de malnutrition que l'enfant présentait déjà depuis avant même sa naissance. On va donc vers l'âge de 2-3 ans, l'âge à risque pour le NoMA, se trouver avec un enfant extrêmement mal nourri, qui affaiblit et qui va rencontrer les premières maladies de l'enfance ou sa première crise de malaria, et ce sera donc la porte grande ouverte à la survenue du NoMA. Et je conclurai par quelque chose qui est d'habitude la manière de commencer une présentation sur une maladie, et c'est l'épidémiologie. En effet, d'habitude, on commence par dire, voilà, cette maladie frappe tant de personnes par année, c'est-à-dire l'incidence de la maladie. Ou alors, on va dire, cette maladie est présente dans le monde chez tant de personnes, c'est-à-dire la prévalence. Ou alors, on voudra présenter dans quelle région du monde cette maladie est plus ou moins fréquente. Eh bien, pour le NoMA, j'ai expressément gardé cela pour la fin, parce que ça reste encore une grande question ouverte. Je vous montre ici quelques chiffres. La prévalence, par exemple, par l'OMS, qui dit qu'il y a dans le monde environ 700 000 survivants de NoMA. Et toujours l'OMS qui nous dit que l'incidence du NoMA serait de 140 000 cas par année. Il y a d'autres études qui, par contre, mentionnent une incidence qui varie entre 30 et 40 000 cas par année dans le monde. Vous voyez que ces chiffres sont extrêmement... La fourchette est très large. Ces chiffres sont en fait des extrapolations qui se basent sur un taux de consultation et ensuite on multiplie ça pour la population globale à risque. Et pour ce qui est des pays, c'est vrai qu'on dit toujours que le NoMA est une maladie africaine, alors qu'en fait, comme vous le verrez plus tard avec le docteur Leila Srour, le NoMA est présent également en Asie ou en Amérique latine. Il est pour moi invraisemblable que la dimension globale d'une maladie qui est si ancienne, si mortelle et si mutilante ne soit toujours pas connue. Et j'ajouterai que ce ne sont pas seulement l'incidence, la prévalence et la distribution du NoMA qui sont méconnus, mais ce sont également ses coûts économiques et sociaux et surtout son poids en souffrance humaine. Quand je parle de souffrance humaine, j'entends la mortalité, l'handicap, la mutilation, la stigmatisation dont souffrent tous ces enfants. Pour cela, je suis heureuse de participer au NoMA Project qui va vous être présenté plus tard dans la journée par Johanna Sismas et qui est un projet qui vise entre autres à combler ces manques de connaissances. La dernière chose que je voudrais ajouter, c'est que cette maladie est tellement négligée qu'elle ne figure même pas sur la liste des maladies négligées de l'OMS. Je vous laisserai donc avec cette réflexion et je vous remercie pour votre attention et pour vos questions. Merci.
So a huge thank you to our speakers introducing NoMA, and particularly to Fidel for sharing this really very personal perspective on this disease, and to all of these presenters for giving us the unified message that the time is right to lift NoMA out of widespread neglect on an advocacy level. So let's focus now a bit more on what's happening in the field, the distribution and determinants of NoMA across the world, its epidemiology, but also how it's being tackled. In this next session, we will hear across time and continents. Dr. Klaas Mark, plastic surgeon and chairman of the former Dutch Noma Foundation, will be taking us through a fascinating historic overview of NoMA with lots of lessons to be learned. We'll then also hear a selection of in-country experiences. First, from Dr. Leila Sroor, pediatrician and principal member of the NOMA project, about NoMA in Laos. We'll also see footage straight from Sokoto State in Nigeria, and I'll take this opportunity to salute all of our colleagues tuning in from Sokoto. We'll then hear from Dr. Rose Drabo, head of the Oral Health Department and the National Noma Control Programme at the Ministry of Health in Burkina Faso, to give us a local update. And again, a quick shout out to all our participants joining us from Burkina Faso and in fact from all around the world. So through these presentations, please, by all means, keep your comments, questions, and any thoughts coming by adding them into the chat box. We'll also have a chance for a live discussions right after this segment, and I'm really looking forward to this. But in the meantime, first and foremost, to open this section, looking at the global presence of NoMA, please join me in warmly welcoming from the Federal Ministry of Health, Nigeria, the Honorable Minister of Health, Dr. Osagie Ehenire.
I am pleased to join this gathering of dedicated stakeholders in the NOMA world at this international conference themed NOMA, a neglected disease. NOMA, also known as Cancrum oris, is still poorly understood and is a rapidly progressing necrotizing infection of the mouth and face with a high mortality rate, which can be within 2 weeks of onset if untreated. NOMA occurs among 2 to 6 year olds, severely malnourished or immunocompromised children of poor, uneducated rural women in poor hygiene and sanitation settings. Most children who survive the disease retain severe facial disfigurements, which affect both speech and feeding abilities and the prospects of community acceptance. NOMA is found in very low-income countries or such with extreme inequities, especially in sub-Saharan Africa, having been eliminated in higher-income countries. It can also be an indicator of worsening economic crisis in conflict settings during natural and man-made disasters, all of which are with deteriorating sanitation, declining nutritional status, or during incidents of disease outbreaks, such as the ongoing COVID-19 pandemic. All of these circumstances reduce access to quality nutrition and healthcare, adversely affecting health and well-being of children. Apart from the poor general health and premature death, NOMA patients, who are mostly children and young adults, suffer from high levels of stigma and social exclusions in their communities, an experience which no child should be left to undergo. Nigeria is pursuing a number of initiatives to raise awareness of NOMA in vulnerable communities. These are institutionalization of annual commemoration of the National Noma Day, so that government and the political class are better informed about its gravity, given its rising prevalence. Sensitization of stakeholders on the need for quick sustained action against the disease. Establishment of the National Noma Control Programme with dedicated funding from the federal government and HIF's Action Noma EV through the World Health Organization. The priority target of this fund is to support disease prevention and capacity building of health workers on early detection and counseling on nutrition and hygiene, which have been done in several communities. Nigeria has also constituted a technical working group made up of renowned scientists and academics of repute to advise government on best ways to tackle Noma. This disease condition is preventable if modifiable risk factors such as malnutrition, poor hygiene, and lack of effective immunization services in certain remote communities were addressed. Government also uses a multisectoral approach to curtail effects of Noma through collaborations such as between the Noma Control Programme and the National Orientation Agency to communicate social and behavior change through National Orientation Agency channels. With the National Primary Healthcare Development Agency to ensure that children are immunized against preventable diseases. With the Nigeria Center for Disease Control to ensure daily notification of this disease using the Integrated Disease Surveillance and Response System. I conclude by thanking organizers of this conference. I'm confident that groups gathered here will further define ways and means to address this disease. The political will to tackle Noma in Nigeria is strong, and we are ready to support Noma-related initiatives that can include resolutions reached at this conference. I thank you all for your attention.
Good afternoon, everybody. My name is Klaas Mark. In 1996, I was member of the first surgical mission to Sokoto, Nigeria, to operate upon victims of Noma. It was an experience that changed my life. Because I hardly knew anything about this affection, I decided to study its history and to publish as much as possible about the history of Noma and the surgical rehabilitation of surviving Noma patients in order to raise attention for this unknown disease. This historical research resulted in the book Noma, The Face of Poverty. It tells that Noma is indeed an old companion of mankind. One can find it described in the 2,000-year-old books of the Roman encyclopedist Celsus and the Greek physician Galen. In medieval medical books, we find Noma described as water cancer. This because in the initial phase of the disease, patients are drooling extremely due to hypersalivation. That water cancer was not cancer, a malignancy, but an ulceration, or as we say today, an infection, was recognized by the Dutch physician Cornelis van der Voorde in the 17th century. He coined the term Noma for the disease. And Noma is the Latinized form of the Greek word noma, meaning pasture land, and also the grazing of a herd. It also has a metaphorical meaning of a quickly passing process, like a wildfire, as we say nowadays. So Noma was recognized as a clinical entity, a very quickly spreading infection in the mouth, like a hungry herd eating a green pasture land. Also notable is that in already 1649, Arnoldus Boethius published the first book about neglected diseases, Observationes de affectibus omissis, which means observations of neglected diseases. And it has, of course, a chapter about Noma. In the 17th, 18th, and 19th centuries, Noma was a common disease in most, if not all, European countries. A correlation with measles was described. It was considered correctly as a non-contagious disease, and the mortality appeared to be around 90%. The first surgical procedures for the repair of facial defects in the rare surviving patients were already developed during these centuries. The first health statistics in the Netherlands were collected in Amsterdam, halfway the 19th century. The yearly death rate in children due to Noma was low, 17, only 0.5% of the total child mortality in this town. Noma was present in the city and also in the Netherlands, but clearly not a common killer of children, and neither it's that today. And then, in the second half of the 19th century, suddenly the incidence of Noma drops. It disappears from mortality lists. And already in 1885, a case history of Noma was described in a Dutch medical journal as a rarity, worth to publish. What can explain this sudden disappearance of Noma? Not a better medical treatment, not more hygiene, neither a better quality of housing or drinking water. All came later. Antibiotics even came after the Second World War. The explanation for the disappearance of Noma is very simple. Food statistics show that in the second half of the 19th century, the consumption of food per capita in the Netherlands increased significantly due to economical progress. For the first time in history, poor people in the Netherlands were able to feed their children sufficiently. This history also gives us a historical rule. The rule says that a society only starts to register its dead citizens properly when it's able to feed its inhabitants properly. And so health statistics from poor countries are by definition not reliable. Thus, nobody in the world knows the yearly incidence of Noma in the world. Only rough estimates have been made during the last few decades, ranging from around 30,000 up to 200,000. Nothing more than pure guesswork. Early pathological studies at the end of the 19th century revealed in Noma lesions many different microorganisms in the transitional zone between the gangrene and the healthy tissue. All these microorganisms are also present in healthy persons. You and I, we all have them in our mouth. This indicated that there is no specific microorganism that causes Noma. And these old observations prelude the present notion that Noma is not a specific infection like, for example, tuberculosis, leprosy, or COVID-19, but just an opportunistic infection in an extremely weakened and vulnerable human being. The normal microbiological flora starts to eat the body in which it lives. So our body needs food or will be eaten by itself. History also shows that antibacterial drugs like sulfa drugs and antibiotics are good in treating Noma patients at an early stage. They reduce the mortality significantly. That history can be ironic is evident. The usefulness of these drugs was demonstrated for the first time in German concentration camps in the Second World War, where many prisoners developed Noma as a result of severe malnutrition. From this historical review, one can draw several conclusions. The first is the incidence of Noma in a population is a good index for extreme poverty and malnutrition in this population. The second is Noma can be prevented completely by food security. That Noma still exists in the world is a disgrace for mankind. And the third is Noma was mentioned in the first book about neglected diseases centuries ago already. However, nowadays, one should consider it as a neglected disease because it's still not recognized as a neglected tropical disease. That is, in my opinion, also disgraceful. I thank you for your attention. It was a privilege to speak to you.
Good afternoon. I am Lila. I'm a pediatrician. Thank you for giving me this opportunity to share experience about the hidden face of Noma in Laos. The WHO map of reported Noma cases in the literature shows the geographic distribution of reported Noma cases. There were no cases reported from Laos, a country in Southeast Asia surrounded by Thailand, Myanmar, China, Vietnam, and Cambodia. The Lao Ministry of Health stated that there were no cases of Noma in Laos. The map was prepared in 2000 by the staff of the International Action Program Against Noma of the World Health Association. After 20 years of practicing pediatrics with a master's in public health and a diploma in tropical medicine and hygiene from London, I moved to Laos to volunteer with Health Frontiers supporting the training of Lao pediatricians. Despite my education and experience, I had never heard about Noma. While visiting a remote village, I observed signs of extreme poverty and childhood malnutrition. Just before leaving, the village health worker asked me to see his daughter, Moan, who was sitting in their one-room house with her face hidden against the wall. She was 16 years old, with a hole in the side of her face and unable to open or close her mouth. She was normal at birth until 4 years of age, when she became ill with cheek swelling, followed by bones and teeth falling out. She was very shy and isolated, even in this remote village. I consulted with Klaus Mark and learned about Noma. 5 months later, my husband, a photographer, was visiting a remote district hospital and noticed a young child with a gangrenous lesion. The healthcare professionals did not know the disease or what to do. My husband told them about NOMA and gave support for antibiotics and nutritional support. This little boy is Tao Dam. While looking for help for these two patients, I opportunistically encountered other NOMA survivors in Laos. We published the first report about Lao NOMA survivors in 2008. With an untreated mortality of 90%, survivors of NOMA may represent 9 others who did not survive. It is estimated that less than 10% of survivors have the opportunity to seek surgical rehabilitation. 50 NOMA survivors from 14 of 17 provinces have been identified. The patients are evenly distributed by sex and range in age from 15 to 60 years, with a median of 40. Their age of onset of acute NOMA ranged from infancy to 12 years, with a median of 4 years. They all reported suffering from the stigma of their appearance and functional impairments throughout their childhood, adolescence, and often early adulthood, before having the opportunity for surgical rehabilitation by international teams. In 2006, Moan was treated surgically in Singapore to relieve her ankylosis and close the facial defect. Her treatment was accompanied by positive changes in the quality of her life. She married and had 3 children. In 2006, the Dutch surgical team bridged the gap, working together with Lao surgeons, began offering surgical rehabilitation for Lao NOMA survivors, including Dam. Nguyen, affected by NOMA in the first year of life, suffered from stigma and social isolation for 17 years, her childhood and adolescence. After surgery, she has a new face, confidence, and hopes to continue her education. Tao Yeo, a 29-year-old man, had NOMA at 6 years of age. He suffered from ankylosis, loss of sight in one eye, teeth extruding from his cheek, and psychologically from stigma and isolation, continued to live with his grandmother. After surgical rehabilitation in 2017, which required a 6-month hospital stay due to complications of a pectoral flap failure, he was able to return to his village. He married, built a simple home, and started a family. He became an outgoing and enthusiastic individual, grateful for the changes in his life. Surgical rehabilitation resulted in Gadam being able to get a job, support his family, and experience the joy of not hiding his face. He spent over 20 years suffering from stigma and dysfunction, his childhood, adolescence, and young adulthood. The improved psychosocial outcomes for many of these survivors appears greater than the cosmetic and functional outcomes of their treatment. Here's a picture of Nang Nai, the way we first saw her. 50 Lao NOMA survivors have been interviewed and consented to share their photos and stories. 44 patients have had at least 1 surgery. Follow-up at least 1 year later revealed improvements in the quality of life, even though surgery cannot restore normal appearance. These survivors suffered from stigma, physical and functional disabilities, and social isolation for decades, a median of 25 years, including childhood and adolescence. Often unable to attend school, excluded from their communities, challenged to form close relationships. Survivors of NOMA remain hidden, a shocking reminder of their childhood preventable disease. Holistic and surgical rehabilitation can significantly improve their lives. Efforts to find survivors and support their care should not be delayed. The lack of inclusion of NOMA on lists of NTDs perpetuates the neglect of this preventable childhood disease, mortality, and the decades of suffering of NOMA survivors. Thankfully, PLOS NTDs now includes NOMA in their list of neglected tropical diseases. A publication on the lives of Lao NOMA survivors will be submitted. Working together with all of you and the SNIS-supported NOMA research group, we hope that WHO will include NOMA in their list of neglected tropical diseases to support efforts to eradicate this preventable childhood disease and support the surgical rehabilitation of the survivors who are often hidden due to the stigma and physical deformity. Thank you very much. Please enjoy the rest of the conference.
Merci à tous ceux qui sont connectés. Aujourd'hui, nous avons l'opportunité, grâce à cet événement en visioconférence, de parler du NOMA au niveau du Burkina Faso. Je suis le docteur Rose Drabo, chirurgien dentiste et spécialiste en santé publique, responsable du service de santé bucco-dentaire et de lutte contre le NOMA. Le programme national de lutte contre le NOMA est un ensemble d'activités de soins curatifs et de prévention du NOMA par la formation du personnel de santé, l'appui des structures sanitaires en médicaments et consommables, l'appui des associations et ONG dans la prise en charge des patients et la sensibilisation des populations sur le NOMA. C'est un programme du ministère de la Santé logé au niveau de la direction de la prévention et du contrôle des maladies non transmissibles. Le Burkina Faso s'investit dans la lutte contre le NOMA par l'amélioration de la qualité de vie de l'enfant et sa survie, par l'adoption des mesures sans précédent de la gratuité des soins médicaux chez la mère et chez l'enfant de moins de 5 ans. La prise en charge du NOMA commence au Burkina Faso dès le centre de santé de promotion sociale appelé CSPS, qui est souvent le premier niveau de contact de la maladie dans la pyramide sanitaire. Dans ce centre de santé, des perfusions de sérum, de l'administration d'antibiotiques sont commencées, puis le malade est référé à un centre hospitalier. La réparation des séquelles est chirurgicale. Elle est faite au centre hospitalier universitaire par des chirurgiens. Aussi, il y a des missions organisées par des ONG. Je peux citer Sentinelle, In aux enfants. Chaque année, il y a des missions qui arrivent au Burkina Faso pour la prise en charge des enfants atteints du NOMA. En passant, je salue, je remercie toutes ces ONG qui accompagnent ces enfants, qui accompagnent le Burkina Faso, qui accompagnent le ministère de la Santé pour la prise en charge de ces patients. Nous savions très bien que le NOMA rime avec la malnutrition. Cette étude, l'enquête nutritionnelle de 2017, nous a révélé, et c'est effectif, que la région du Sahel est la plus touchée parce que nous avons un taux de malnutrition aiguë de 13,6. Aussi, la région de l'Est a un taux de malnutrition de 10,8 et nous rencontrons de nombreux cas de NOMA. La dernière région, c'est la région du centre-nord avec un taux de malnutrition aiguë de 9,4. Donc, la plupart des cas de NOMA répertoriés se trouvent au niveau de la région du Sahel, de la région de l'Est et de la région du centre-nord au Burkina Faso. Le NOMA est une maladie grave, est une maladie de santé publique et on doit se pencher, on doit prendre des décisions fortes pour le bien-être de nos enfants pour le bien-être de nos populations. Je vous dis merci, merci encore pour tout le travail fourni. C'est ensemble, c'est en multipliant, c'est en faisant une convergence de nos travaux, de notre engagement, que nous viendrons à bout du NoMA. Je vous remercie et encore bonne et heureuse année 2021, qu'ensemble nous boostons hors de nos pays le NoMA. Bien à vous.
So welcome back following from this Q&A session. Once again, I can't repeat enough how hugely important, encouraging, and energizing it is to see you and so many participants representing a huge range of countries, but also number and types of organization across very different disciplines, from human rights to WASH, via diagnostics and primary healthcare, all coming together to find out more about what can be done about the devastating and really haunting disease that is NoMA. But these very passionate multi-sectoral collaborations and this inherent partnership in tackling a disease like NoMA are not new. And some of the organizations with us here today, and in fact some of the individuals within them, have been working in this field and advocating for NoMA patients for years, if not for decades. As they often say, once you hear about or encounter NoMA, it can never really leave you. So in this next part of our conference, and in fact the rest of the event, we will be looking at what's really at stake here and the true burden of NoMA, and to really convey not just the urgent public health dimension, but the moral imperative of accelerating the fight against NoMA, I'm both delighted and honored to welcome some incredibly passionate and long-standing advocates. Firstly, please join me in welcoming Mulikat Okanlawon. Mulikat is a NoMA survivor and advocate and is now hygiene officer at the NoMA hospital in Sokoto, Nigeria, where she was treated some 20 years ago. We'll also hear from Dr. Joanna Chishmash, based at the York Law School and Center for Applied Human Rights, and also project coordinator of the NoMA project. And Joanna will be presenting some of the preliminary findings from an interdisciplinary exploration of the realities, burden, and framing of the disease NoMA. Also, please do bear in mind that as earlier in the event, we will also have, after these presentations, a second opportunity for a Q&A session. So please do collect all your thoughts and questions that may arise during these presentations, and we will swap over to the sessions room for this interactive Q&A and chat. But now to open this section, I'd like to hand over to a hugely passionate and outspoken ambassador for NoMA, a psychiatrist and explorer, someone who has used his voice to raise the profile and awareness of this disease, as well as bring numerous partners together. Please join me in welcoming Dr. Bertrand Picard, co-founder and spokesperson for the International NoNoma Federation, bringing together over 30 organizations working to tackle NoMA and support patients.
Bonjour à tous et à toutes. Le NoMA, quand on ne l'a jamais vu, on ne peut pas imaginer que ça existe. Et quand on l'a vu, on ne peut plus jamais l'oublier. Moi, je me rappelle que le premier contact avec une fillette atteinte du NoMA, c'était il y a 20 ans. Et un peu naïvement, j'avais cru qu'elle avait reçu un coup de hache dans le visage parce que je n'avais pas d'autre explication. Et en fait, c'est une petite fille qui venait d'être opérée d'un NoMA. Elle avait été amenée en Suisse pour ça. Et ça m'a tellement bouleversé, j'ai été voir Edmond Kaiser, qui est en fait celui qui a fait connaître le NoMA dans le monde et qui m'a expliqué la situation, ce symbole de la pauvreté absolument inacceptable, qu'on peut guérir tout au début avec quelques euros d'antibiotiques de base. Et si on manque de diagnostic, comme c'est pratiquement toujours le cas, eh bien, c'est des séquelles abominables, c'est des souffrances intolérables, c'est beaucoup d'enfants qui meurent. et de temps en temps un enfant qui peut être guéri ou réparé par de la chirurgie esthétique ou reconstructive plutôt. Donc, c'est clair que ce qu'il faut faire, c'est agir à la base, agir au moment des premiers symptômes. Et c'est pour ça qu'après le tour du monde en ballon avec Breitling Orbiter 3, nous avons créé la fondation Winds of Hope, les vents de l'espoir, pour agir justement là où très très peu de gens agissaient, c'est-à-dire dans la détection précoce, dans la prévention du NoMA avec des programmes d'éducation au niveau des ministères de la Santé, au niveau de toutes les cases de santé sur 6 pays d'Afrique subsaharienne. J'ai vu à quel point il y avait beaucoup de bonne volonté, beaucoup d'acteurs, ce qui fait que j'ai eu envie de les fédérer. C'est comme ça qu'on a créé la fédération NoNoma, de manière à avoir à peu près les 30 principales organisations luttant contre le NoMA qui renforçaient leurs actions en travaillant ensemble. Et puis maintenant, c'est clair, il faut voir les choses en face. C'est très difficile d'aller sur place. Le terrorisme, le djihadisme fait que ces régions sont dangereuses, sont instables. Donc, on continue à agir, mais à travers des organisations locales, indigènes, qui arrivent à gérer les risques mieux que des étrangers. Et puis, sur le plan international, bien sûr, le combat continue. Et ce qui est absolument fondamental, c'est de faire connaître cette maladie, la faire reconnaître également. Et le NoMA avait été accepté au niveau des Nations Unies comme une atteinte aux droits humains dans le cadre du droit à l'alimentation. Mais aujourd'hui, ce qui manque extrêmement clairement, c'est la reconnaissance du NoMA par l'OMS comme une maladie tropicale négligée. C'est un gros travail à faire. On n'a pas réussi jusqu'à maintenant, malgré tous les efforts de la Fédération NoNoma, de tous les membres. Et je vois maintenant Médecins Sans Frontières qui prend une part importante dans cette lutte du NoMA et ça me donne beaucoup d'espoir. C'est beaucoup d'encouragement. Nous nous sentions très seuls en ayant des organisations finalement très petites qui agissaient localement, qui essayaient de fédérer, mais il nous manquait un grand acteur. J'avais parlé du NoMA à Bill Gates, il n'a visiblement pas percuté. Médecins Sans Frontières, qui maintenant s'engage de cette manière-là, et pour moi un immense soulagement. J'ai l'impression que la lutte peut reprendre un deuxième souffle, sur le terrain bien sûr, dans des pays que nous n'avons pas encore pu toucher. Il y a des pays encore avec du NoMA dont personne ne s'occupe. Et puis, continuons cette lutte tous ensemble pour faire reconnaître le NoMA sur le plan politique, sur le plan médiatique, sur le plan institutionnel à l'OMS. Et je pense que c'est impossible, évidemment, de nourrir toute l'Afrique et qu'il n'y ait plus aucun cas de malnutrition, alors que le NoMA vient en bonne partie de la malnutrition, surtout la malnutrition des mères pendant qu'elles sont enceintes. Mais par contre, c'est possible de faire cette prévention secondaire, de détecter les cas assez tôt, de faire cette éducation des agents de soins et de prévenir la désintégration des visages de ces enfants. C'est une image qui est inacceptable au XXIe siècle et qu'il faut absolument arriver à éradiquer totalement. Donc, extrêmement heureux de pouvoir collaborer avec Médecins Sans Frontières, aidons ensemble vraiment ceux qui en ont besoin dans cette tragédie du NoMA.
Good afternoon, everyone over there. My name is Mulikat Okolawa. I'm from Sokoto here, Nigeria. So I'm a patient, NoMA patient. I came from Lagos for the operation. Then after the operation, then they now offer me a job in Sokoto Hospital here, NoMa Children's Hospital. When other patients are seeing me, they will know that after NoMa disease, after surgery, there is life. The life has not gone with NoMa. About the disease, not everybody knows about it, because even us, we didn't know that there is a name for the disease until we came for the surgery. Then they now call it NoMa. So when people see me, Some thought it was accidents. They are thinking many things, but majority of the people thinking this thing is accident to me. Some people come to me and say, Malika, is it accident that do you like this? At times I will say yes. Because by then I didn't know the name for it. I will say yes. Because I was small when the thing started. It happened to me. So I couldn't, I can't really say much. But when they say, is it accident? I say yes, it's accident. So people do ask, some, not everybody, because there is stigmatization, because people doesn't want to do anything with you as a normal patient. Because when they see you like that, some will run away, some will come closer to you, some will like to make friends with you, some they doesn't want. So that's just my message. Let us, all of us together, Nigeria, all over the world there, let all of us join hands together to raise the awareness of these Noma diseases, because every day, like now in Nigeria, in our hospital presently, as I'm talking to you, we are seeing fresh Noma every day with children. This disease is just, it's just going out, rampant now, despite there is surgery. I mean that there is no surgery for it. What can we say? So I just want every one of us as a medical personnel, even if you are not a medical personnel, but you know somebody that is working in the hospital as a medical personnel, and you see anybody with this Noma disease, just try to get in touch with that person. I saw so person, this is the condition, then the person will now, will now help you out. That's my advice to everybody. Thank you for having me this afternoon in your meeting. And I believe by the time as you are seeing me, you are hearing my voice, you too, you are going to take message to where you are staying, your country, in your workplace, whether you are working in the hospital or you are working outside the hospital. The message is still, I believe that you will take the message all over wherever you go. So I'm grateful for everything. I thank you so much, and I wish you well.
T'as vu? Ça, c'est le Noma. Hein? C'est la maladie du Noma, de la faim, quoi, qui détruit d'abord le visage des enfants. La faim, c'est le crime organisé. Et on peut désigner les assassins. Je la garde toujours dans mon manuscrit de conférence pour que je sache pourquoi je parle, tu vois. Tu vois ça? Parfois, la motivation baisse devant une salle. Tu dis, merde, on a une conférence, alors. C'est pour ça que j'ai avec le World Food Report, tu vois, enfin qui sont les chiffres, si quelqu'un m'attaque, les chiffres de l'ONU sur le massacre, mais c'est ça qui me motive. C'est pour cela que je parle, tu comprends? Et derrière, toujours aussi, il y a la Déclaration des droits de l'homme. Ce que ça devrait être homme sur terre, tu vois. Ça, c'est des armes. C'est des armes pour l'insurrection des consciences.
I should like to start by expressing my profound gratitude to the organizers of this conference. I am particularly encouraged to see survivors of Noma sharing their experiences as part of the event. Centering their voices is crucial in any endeavor aimed at preventing and treating Noma. The project Noma, the Neglected Disease, an interdisciplinary exploration of its realities, burden, and framing, about which I will be talking today, equally seeks to achieve such a centering of those affected by Noma. My name is Dr. Jana Chismas. I am an international and human rights law scholar based at the Center for Applied Human Rights and the York Law School in the UK. My research on Noma started in 2009 when I joined the team of legal advisors of Jean Ziegler, a member of the advisory committee of the UN Human Rights Council. In that capacity, I drafted a number of studies on discrimination in the context of the right to food, as well as on Noma for the advisory committee. Today, I'm conducting practice-oriented interdisciplinary research on Noma, together with dear colleagues at the Institute of Global Health at the University of Geneva and the Swiss Tropical and Public Health Institute in Basel. Our research would not be possible without close partnerships and collaborations with non-governmental organizations, intergovernmental organizations, and governmental bodies. And this includes the Fondation Sentinelle, Health Frontiers Laos, Hilfsaktion Noma, Médecins Sans Frontières, Songe, Winds of Hope Foundation, and the International NoNoma Federation, the World Health Organization, relevant governmental bodies in Burkina Faso and Niger, and a number of academic partners. We benefit from conceptual, methodological, and operational input and support. And we hope that through such collaborations, we will be successful in achieving our project's overarching aim. And this aim is to generate academic and social impact at local, national, and international levels by providing a better understanding of Noma and engendering action to prevent, detect, and treat this disease and to redress the associated human rights concerns. Specifically, our research seeks to provide empirical as well as conceptual data to support efforts for the inclusion of Noma in the World Health Organization list of neglected tropical diseases. Our research focuses on 3 major pillars. And I should say that we are 1 year in the project. So what I will be presenting today will be some preliminary findings, while also presenting some of the forthcoming work that we have planned. So first, what we seek to do in the project is to further clarify Noma's epidemiology and its global burden. The data that we have now on Noma's epidemiology paints a bleak picture. 140,000 children are estimated to be affected yearly by Noma, and there are 770,000 Noma survivors worldwide. This is data produced by the WHO dating to 1998. Whilst many of those affected by Noma are in sub-Saharan Africa, Noma is not confined to this region. My colleague Leila Sroor concludes that it is likely that Noma is much more frequent in remote Asian rural communities than is currently appreciated. This disease is highly deadly. Its mortality and morbidity rates are far greater than those of many other diseases that are formally included in the WHO list of neglected tropical diseases. However, at the moment, we lack an accurate estimation of Noma's global burden. As such, a cause of substantial human health and life loss may be largely neglected and unaddressed, or indeed is largely neglected and unaddressed. And it is at this juncture where the outputs of our project become important. Colleagues at the Swiss Tropical and Public Health Institute in Basel involved in this project have been conducting a systematic literature review, searching 11 databases, screening titles and abstracts and full text. This systematic literature review, which will be finalized in spring 2021, will be refined based on results from a complementary epidemiological analysis of existing patient records, which will also be finalized this year, as well as household cross-sectional studies in Burkina Faso and Niger, which we aim to undertake later this year. Building on these results, disease models will be established, parameterized, and quantitatively analyzed in order to estimate the global burden of NOMA in disability-adjusted life years, or DALYs, by using the methodology, definitions, and specifications of the Global Burden of Disease Collaboration. By mid-2021, we hope to be able to share up-to-date epidemiological data on NOMA and a global burden estimate, which should then in turn assist advocacy efforts for the inclusion of NOMA in the WHO list of neglected tropical diseases. The NOMA project's second research pillar focuses on the lived realities of children at risk and children and adult survivors of NOMA worldwide, including in Asia. And we focus on two specific aspects: the risk factors, social determinants, and socioeconomic costs of the disease, as well as the realization of survivors' human rights. Certainly, to prevent and treat the disease, we need to understand what causes it and how it manifests itself. However, there is another imperative for focusing on the lived experiences of children and adults at risk of and with NOMA. This is, in my view, at the very least, a moral responsibility, if not legal, that stakeholders have to listen attentively to the voices of those individuals who are affected by this disease. In our efforts to address NOMA, we must be guided by their experiences and seek to center their voices and their actions. And in this respect, I'm particularly encouraged by the step-by-step guide to develop national action plans for NOMA prevention and control in priority countries. This is a document that has been recently produced by the WHO's Regional Office for Africa. And this guide specifically recommends that, and I'm citing, survivors of NOMA and their families should be involved in drafting National Noma Control Programme action plans. And the rationale for this is because such an approach would ensure the participation of those most affected by the disease and be informed directly by their experiences. One of the methods that my colleagues from the Institute of Global Health at the University of Geneva are using to portray the experiences of those affected by NOMA relies on extensive archival research. The Fondation Sentinelle has provided the research team with access to their archive of records of NOMA patients treated by Sentinelle care centers in Burkina Faso and Niger over the last 3 decades. The archive consists of over 1,500 socio-medical surveys. My colleagues have designed and tested a detailed and complex database that includes general information on the patient, the story of the disease, so the age when acute NOMA appeared, when it was first diagnosed, the type of lesion, first signs, symptoms, and so on. Information on patient care, information on healthcare access, including the distance to the near healthcare center, hospital, information on the family composition, on nutrition, hygiene, family income, housing, the level of education, access to work before and after NOMA surgery, the impact of NOMA on the child's life. How did they experience the disease? What were the consequences on a range of activities, as well as the impact on the family and the family dynamic? Now, some of the early findings confirm what other studies have previously hinted towards, but they confirm so with far greater detail and with a richness of information that we haven't had access to before. For example, in 2012, the UN Advisory Committee of the Human Rights Council study had found that NOMA occasions some of the worst violations of the rights of the child and has specifically highlighted discrimination as an issue of major concern. Now, the preliminary results from the archival research confirmed that nearly 30% of children experience some form of discrimination, with 15.5% being rejected by their parents or peers. Moreover, 38.5% of parents have considered the disease to be a shame on the family, and 7.7% of families have been rejected by their village community. What this portrays is the important work of awareness raising that needs to occur to destigmatize Noma and to redress discrimination. New and refined findings are also extremely useful to understand where interventions should zoom in, where we should really focus. For example, early results suggest that 82.4% of parents of children with Noma do seek help during the first week of the disease. This is very early, and it's vital because of the fulminant progression of Noma. At the same time, our findings show that the families seek help from traditional healers. 72.4% have sought their help, and from the local integrated health centers, 67.1%. This suggests that it is vital that stakeholders train traditional healers and healthcare workers at local level to detect and treat early Noma, and also to enable them to refer more advanced cases of Noma to relevant healthcare facilities when available as soon as possible. The second pillar of research will also rely on other methods, such as extensive field work in case study countries, consisting of interviews with Noma survivors and their families. We would have hoped to be much farther advanced with these interviews. However, COVID-19 happened. We will also develop a socioeconomic cost estimation of Noma, providing information about the cost of access to healthcare, the costs relating not just to treatment, but also things such as nutrition. And we have undertaken a legal doctrinal analysis, pinpointing the rights of those at risk and surviving Noma, and the obligations of states and other stakeholders in relation to those rights. Coming to our third research pillar, this concerns Noma's framing. Frames are communicative methods that define problems, diagnose causes, and make moral judgments, while also suggesting remedies. They are used to foster support and to motivate action on a specific agenda. Framing theory provides us with insights into what manner of framing may most effectively address the prevention, detection, and treatment of Noma and realization of survivors' rights. Two main frames have been used in the context of Noma by medical professionals, non-governmental organizations, and human rights bodies. The first one refers to framing Noma as a neglected tropical disease, and the second one is a frame of Noma as a human rights concern. Coming to Noma as a neglected tropical disease. This was put forward by actors in the medical community and some, yet few, in the human rights community, including several of the members on our project's research team and our project partners, MSF, Sentinel, Hilfsaktion Noma, Winds of Hope, the NoNoma Federation. The reason why they have done that is because studies strongly indicate that the formal recognition of Noma as a World Health Organization neglected tropical disease could have positive implications for Noma in terms of research, treatment, and prevention. It could also, according to one scholar, and I'm citing, transfer NOMA from the purely medical field into the political domain, therefore attracting attention of policymakers and donors, and therefore eliciting action on NOMA. However, whilst NTD framing of NOMA has been persuasively applied in theory, at least that's my view, it is yet to be realized in practice. We have undertaken as part of our project key informant interviews, trying to understand why the framing has not yet achieved its goal. And the suggested answers are a combination of the scattered and perhaps outdated data on epidemiology, insufficient strategic advocacy on NOMA, insufficient buy-in from affected states and donors, and or a competition among entities and resources, which is the reality of today's world. However, we also see hope from our interviews and based on 3 very recent events. The first event concerns the recognition of NOMA as an NTD by PLOS. And my colleagues, Leila Sroor and Denise Barati-Meyer, have been instrumental in arguing for this recognition. The second important occurrence is the language used in the WHO Afro step-by-step guide that I previously mentioned, which on my reading acknowledges NOMA as a neglected tropical disease. And the third event that I wish to highlight is this very conference, through which MSF, in partnership with the International Society for Neglected Tropical Diseases, with Winds of Hope and the International NoNoma Federation and Inediz, aim to build a coalition allowing us to join our efforts towards including NOMA in the WHO list of neglected tropical diseases. So I'm coming then to the last part of my presentation, the second framing, that of NOMA as a human rights concern. The 2012 study of the Human Rights Council Advisory Committee on Severe Malnutrition and Childhood Diseases with Children Affected by NOMA as an example. These UN studies have very long titles. So this study was the first iteration of NOMA's framing from a human rights perspective. It identified the human rights of individuals at risk of or with NOMA that are at stake. And this include the right to food, to water and sanitation, to health, to housing, to education, to life, freedom of expression, the right of children with disabilities to a full and decent life, and the right to equality and non-discrimination. The study also aimed to pinpoint some of the state's obligations that arise in the context of this disease, including by drawing up guidelines for a human rights-based approach to NOMA. Interestingly, one of the recommendations of the study and the guidelines was that NOMA should be included in the WHO list of neglected tropical diseases. Findings from key informant interviews that we have conducted suggest that the 2 framings of NOMA as an NTD and NOMA as a human rights issue are largely compatible. And what we are now exploring is an interesting sub-framing that portrays prevention and treatment of NOMA, so the focus of states on individuals at risk and with NOMA, as progress towards their realization of their obligations relating to human rights. Finally, I would like at the end of my talk to thank the research team of this project for their dedication in hard times, to thank our partners and funders for their support and their work, and to thank everyone involved in this conference and with an interest in NOMA for their perseverance. Thank you.
So welcome back, everybody, after this extremely fruitful discussion. We are back now for the last part of this conference. Now, we've already heard a lot of incredibly inspiring talks about the urgent need for advocacy for Noma. And in this last section, we're really going to keep that momentum going, as well as drill down in a much more practical sense into what this means in terms of prevention and treatment for those affected by Noma. From case detection, of course, in remote communities to surgery, but also physiotherapy and post-operative care, including mental health support. We will hear from a few organizations out of the many already working in the field, but also at the international level on what has been done and what still remains to be done to prevent and treat Noma and ultimately truly pull the affected patients and their communities out of this ongoing neglect. So I'd like to welcome very warmly, first and foremost, Dr. Bukola Oluyide. Dr. Oluyide is Deputy Medical Coordinator at Médecins Sans Frontières, and she will be charting MSF's holistic approach to supporting the Noma Hospital in Sokoto in Nigeria. It's also my pleasure to welcome Dr. Issa Hamadi. Dr. Hamadi is Medical Director of the Noma Hospital in Niamey, Niger, working for the NGO Hilfsaction Noma. And Dr. Hamadi has decades of experience working as a surgeon and will be highlighting the specific challenges of facial reconstruction. Finally, we're also truly delighted to welcome Dr. Yuka Makino, Technical Officer at the WHO Regional Office for Africa. And Dr. Makino will chart the global and regional milestones of the World Health Organization's action in efforts to tackle Noma. And this since its recognition as a public health issue all the way back in 1994. But first and foremost, it's my greatest pleasure to hand over at this point to Dr. Christos Christou, International President at Médecins Sans Frontières, this year particularly being an important landmark for this organization as it celebrates its 50th anniversary of tireless humanitarian work. Dr. Christou will be reminding us of the paramount need for a patient-centered approach to Noma control and the imperative need to bring Noma out of neglect. So I now hand over to Dr. Christou.
Good afternoon, everybody, and it is such a pleasure to be here with you. It is such an interesting topic. Just to bring you my own experience in this, although being a surgeon myself and having worked with MSF for many years, I wasn't aware about Noma disease until last year. I visited our projects in Nigeria, and that's how I get familiar with something so interesting to deal with. I think it is important to highlight a few points here. I think the fact that Noma affects the most vulnerable, it's a very important thing to take away as a message. Mainly young children, of course, under 5 years old of their age, but there are plenty of adults having survived who need care. There are people living in extreme poverty and dealing with malnutrition and lack of hygiene. This is something that we should always be taking into consideration. And there are members of isolated communities with limited access to healthcare and vaccination. The lack of data shows also how neglected are the most at risk. Noma is mostly, of course, reported in Africa and Asia, but there is no mapping of its global prevalence. And what seems to be more worrying these days is that there is an increase of new, fresh cases that comes to our attention. We need to understand that Noma is preventable and treatable, but people still die from it because of limited knowledge about the disease, and also because of not being able to detect it and this lack of awareness at all levels from health workers, the community, and of course the stakeholders makes things even more complicated and more challenging. Quite indicatively to mention that MSF started supporting the Sokoto hospital for Noma in 2014. We provided medical care for patients coming from all Nigeria, thanks to different activities, of course. We try to approach it in a holistic way. It is not just about treating the disease itself, which we wish we would be able to treat everyone in the very first stages of the disease. This comes also with nutritional support, with mental health support, and last but not least, the reconstructive surgery that it takes a lot of time and repeated interventions. Noma is a neglected disease, but it's still not included in the WHO, the neglected tropical diseases, even if it fits all the criteria. So MSF today is calling for the WHO to recognize Noma as a neglected tropical disease, so more attention and more resources would be allocated to tackle it. While all this is important, and the fact that so many different stakeholders from NGOs, from the clinical, the academic society, from the human rights society are really interested in how they can do more about this, and the fact that this conference will boost and take it into another level. Let us not forget also the patients and their communities. I think it is the right time to give them a voice, give a voice to the Noma survivors. It is important to work with patients and their communities, as we also do nowadays, working with traditional healers in order to better understand their perceptions, their knowledge of the disease. And by doing so, I think it will be closer to go and find solutions that they can come sometimes we cannot imagine from where, but solutions that we can only bring by raising this awareness and by working together. I want to thank you all for this, and I wish a very fruitful conference. Thank you.
Good afternoon. My name is Bukola Oluide, and I'm speaking from Abuja, the capital city of Nigeria, in Western Africa. I'm here to talk about the holistic approach of MSF to Noma, in which we collaborate with the state MOH in Noma Children's Hospital to provide Noma care to patients who suffer from Noma or who survive from Noma. Outreach is one of the components in which we provide awareness. We go to various local government areas in Sokoto, Kebbi, and Zamfara states to do what we call active case search, looking for Noma cases, educating the community about Noma, using flyers and posters, as you can see in this picture. Due to the increase of awareness of Noma, we've had patients coming from all states in the country. Yashe is one of our Noma patients who came all the way from Borno State with her mother and her 2 siblings. Yashe is 6 years of age. She lost her father due to some violent activities in Borno State. She started a long journey from Borno, and came all the way to Sokoto State. Her mother told us about how she developed a fever, and within a few days, she had a hole in her face. In Noma Children's Hospital, we admit acute Noma cases who would need to have some medical care. They might have some comorbidities like malaria, in which tests are being done to ensure that we treat all of these comorbidities. Patients also receive some more health promotion to ensure that they understand how to prevent Noma to themselves, to their siblings. For health promotion, we try to ensure that they understand how to wash their mouths regularly, at least twice a day. Also learn how to do some hand washing. For some of the patients that receive in the acute stage of Noma, they are usually malnourished. Malnutrition is also known as one of the risk factors for Noma and one of the challenges that we face trying to rehabilitate patients nutritionally. For those who are severely acutely malnourished, we provide some therapeutic foods to them to ensure that they are boosted up nutritionally. For every patient that goes for surgery, 2 weeks prior to surgery, they also receive some nutritional supplements. In the hospital, we also try to ensure that we do some trainings on the locally available foods for patients and their caregivers to learn about, so that they can ensure that when they are out of the hospital, they are able to continue providing nutritional support to their children. When Sefiano was admitted to the hospital, he was 2 years of age. We had to medically rehabilitate him, treating his comorbidities, and also nutritionally. He was given some nutritional therapeutic food to boost up his immunity and make him medically stable. Sefiano is still young to have surgery, but we've been able to ensure that he understands that he has to wait a little bit before surgery is performed on him because of his age. We usually do this as part of our mental health support to all patients, providing individual counseling to our patients and their caregivers so that they understand what has happened to them and what might happen to them in terms of surgery to prepare them for the long journey ahead, the long stay in the hospital, and to also discuss about the stigma that they might have faced in their communities as a result of Noma. We also provide some psychostimulation, has some games and some activities in the hospital just for them to provide some time for them to do other things to reduce the anxiety of waiting in the hospital. We also provide physiotherapy. For physiotherapy is really particular to those who have trismus, which is also known as lockjaw. In this instance, they are not able to move their jaw as a result of one of the complications of Noma. When they are admitted in their acute stage, they are already provided with some exercises to ensure that they start trying to open their mouths. And even after surgery, physiotherapy is commenced to prevent that trismus or lockjaw happens. When Bilia was admitted into Noma Hospital, he was 20 years of age, and he had had Noma since he was 1 year of age. Bilia got to know about Noma by one of the inhabitants of his communities. When he came to the hospital, he did not know that there were other people who suffered the same condition as he. Bilia underwent the holistic approach and was prepared for surgery. He finally had his surgery done and had a nose construction. Bilia is now one of our Noma advocates who tells people about Noma and about Noma Children's Hospital so that they know where to refer patients Like Delia underwent surgery, we provide surgery to our patients in Noma Children's Hospital. In terms of surgery, we incorporate all components. Nutritional components to ensure that the patient is boosted nutritionally prior to and after surgery. Mental health support, particularly important for the young children who are going into the theater, is provided before, where they're able to watch a film, and in the theater, where they try to calm their anxieties prior to intubation. And also physiotherapy support before and immediately after surgery to prevent some complications. In terms of boosting knowledge about Noma, we have engaged in some researches for the past 5 years, in which we try to understand the risk factors surrounding Noma, to understand better the various languages and the various names in which Noma is referred to in the communities, to boost our awareness and our outreach activities. Also understanding the prevalence of Noma in northwestern Nigeria. MSF would enjoin that more is done in terms of research in other Noma countries to build up on this knowledge and for us to understand better. So in terms of increasing awareness, we've tried to do this from the community level all the way to international levels. MSF has been able to, in collaboration, produce a documentary which has built up on the advocacy and the awareness surrounding Noma. In this documentary, we're able to record patients' life in northwest Nigeria, Sokoto, to understand their journey from when they had Noma to after surgery. This is still part of our holistic approach in which we want to increase our knowledge, our awareness about Noma. This conference is also one of those ways in which I am happy to be discussing about Noma, to increase this awareness, for everybody to know about Noma, and for us to trash out ways in which we could ensure that Noma doesn't exist anymore. One of those ways will be including Noma on the WHO list of neglected tropical diseases to ensure that there is more focus, more funding for Noma. I'm really pleased to have given this presentation to you today. Thank you for listening, and thank you so much for your questions.
Bonjour à tous. Je vous souhaite tous mes meilleurs vœux d'abord pour ce nouvel an. Je me présente Dr Ousmane Amadi Issa, je suis chirurgien, chirurgien généraliste, mais j'ai été formé à la chirurgie réparatrice à l'hôpital Saint-Louis de Paris chez M. Servant. Et depuis un peu plus de 20 ans, j'ai quand même travaillé sur la prise en charge du Noma en général avec ceux que je peux appeler les pionniers à la matière au monde, notamment Jean-Marie Servant, le professeur Jean-Marie Servant, le professeur Brigitte Pité, le professeur Dominique Martin, le professeur Jürgen Holle et actuellement le professeur Andrea Smith avec lequel on travaille beaucoup. Donc, depuis 2015, je suis le directeur médical de l'ONG Sakshin Noma et le directeur de la clinique Noma où on prend en charge les séquelles de Noma. Notre travail en fait ici à la clinique Noma consiste à la prise en charge du Noma en général, à la phase de séquelles, mais surtout la prise en charge chirurgicale des séquelles de Noma. Et comme vous le savez, cette prise en charge est vraiment spécifique à tout point de vue. Ce qui engendre plusieurs défis à relever. Tout d'abord, je peux dire que le premier défi est lié aux patients eux-mêmes. Comme tout le monde le sait, le Noma, c'est une maladie, comme on l'a eu à le dire plus haut, qui qui survient chez les enfants. Donc, l'âge de ces enfants peut constituer un défi pour plusieurs raisons. Donc, c'est des enfants qui sont en phase de croissance. Donc, l'âge de prise en charge peut poser un vrai défi. Donc, à quel moment il faut les opérer? Il y en a qui préconisent l'âge d'aller à l'école. Bon, pour nous, il faut pratiquer cette chirurgie le plus tôt possible pour notamment permettre à ces enfants d'aller à l'école assez rapidement. D'autre part, la préparation à cette chirurgie peut être un vrai challenge du fait que ces enfants arrivent très souvent dans un état général très altéré. Donc, il y a un vrai travail de préparation à la chirurgie qui doit être réalisé en amont. Donc, d'autres défis sont liés à la maladie elle-même. Comme vous le savez, le NoMA peut engendrer des pertes de substances très importantes au niveau de la face, d'où la nécessité de plusieurs interventions souvent étalées dans le temps. Je peux vous donner l'exemple de patients que j'ai vus et qu'on a pris en charge dès l'âge de 2 ans et dont on a terminé la prise en charge à l'âge de 18 ans. Et souvent, le défi, c'est de pouvoir retrouver ces patients entre les interventions, surtout lorsque les parents vivent dans les régions frontalières. Ils peuvent, en fonction des années, en fonction des saisons, passer de part et d'autre de nos frontières. Un autre problème est lié, donc ce problème de suivi des patients jusqu'à la fin de la prise en charge chirurgicale peut poser problème. D'autre part, techniquement, il faut savoir que justement, du fait de l'âge de nos patients, il peut y avoir beaucoup de défis à relever. Et notamment, le premier problème, c'est des chirurgies souvent très lourdes qui doivent intervenir chez les enfants. Donc, le premier challenge est lié à l'anesthésie. Donc, des enfants qui doivent être opérés souvent pendant plusieurs heures d'affilée. Les interventions peuvent durer entre 4 heures et 12 heures de temps. Donc, il est impératif, comme vous pouvez le noter, que ces interventions, donc l'anesthésie se passe dans de très bonnes conditions pour que le patient puisse se réveiller dans de très bonnes conditions aussi. Et un autre défi majeur lié à l'anesthésie, c'est même l'intubation. Comme vous le savez, le NoMA engendre très souvent un trismus. Donc, c'est des patients, des enfants qui ne peuvent pas ouvrir la bouche, d'où la nécessité d'une intubation par nasofibroscopie. Ce qui est une intubation assez difficile. Il faut des anesthésistes entraînés et il faut avoir le matériel adéquat pour le faire. Bon, heureusement, nous, ici, au niveau de la clinique NoMA, on a des anesthésistes locaux formés par des collègues occidentaux qui arrivent en toute autonomie actuellement à faire ces intubations difficiles. Et en plus, au niveau de la clinique NoMA, on dispose de nasofibroscopes et tout le matériel adéquat pour ce type d'intubation. D'un autre point de vue, donc, comme je le disais, c'est par rapport aux patients, c'est souvent les interventions que nous faisons peuvent nécessiter la pose de ce qu'on appelle des distracteurs, ce qui peut être contraignant. Donc, le distracteur, c'est lorsqu'on arrive à obtenir une ouverture buccale suffisante, on maintient cette ouverture buccale avec un distracteur que l'enfant doit porter souvent plusieurs mois, et vous comprenez avec moi, vous conviendrez avec moi que ce n'est pas évident chez les enfants. Et souvent, l'intervention consiste uniquement à la pose de ces distracteurs pour faire une ouverture, pour obtenir une ouverture buccale de manière progressive, en faisant une ouverture progressive, et cela peut aussi nécessiter plusieurs mois, ce qui n'est pas évident chez les enfants. Et un des défis majeurs aussi, c'est le type d'intervention. Dans les cas de perte de substances très importantes, on a recours actuellement à des lambeaux libres. Puisqu'au niveau local, il n'y a pas assez de tissu pour couvrir les pertes de substances. Donc, on va chercher ailleurs, donc au niveau de la cuisse, par exemple, dans le cadre d'un lambeau antérolatéral de cuisse, au niveau du dos, dans le cadre d'un lambeau parascapulaire avec ou sans os. Donc, d'où ce qu'on appelle donc la relation de lambeau libre. Qui dit lambeau libre dit avoir recours à la microchirurgie. Et ça, c'est un vrai défi. En mission, déjà, il y a beaucoup de praticiens qui sont réticents par rapport à la réalisation de lambeau libre, par rapport à, très souvent, pas la réalisation technique, mais le suivi post-opératoire. Heureusement que depuis un certain nombre d'années, au niveau de la clinique NoMA, nos équipes sont vraiment entraînées par rapport à cette prise en charge post-opératoire, à ce suivi post-opératoire lorsque ces types de lambeaux sont réalisés. Mais aussi dans la réalisation de ces lambeaux libres, il faut évidemment posséder des instruments de microchirurgie, des loupes, pour la réalisation des anastomoses ou des loupes ou des microscopes. Bon, au niveau de la clinique NoMA, nous utilisons beaucoup plus des loupes, bien que nous disposons d'un microscope, effectivement, pour la réalisation de ces micro-anastomoses. Donc, un des grands défis aussi, c'est effectivement le suivi post-opératoire. Lorsque, je l'avais noté plus tôt, lorsque les patients ont un distracteur. C'est vraiment très difficile de faire accepter à ces enfants, mais on y arrive heureusement de porter ces distracteurs lorsque ces interventions sont réalisées. Et l'autre défi, c'est la rééducation. La rééducation post-opératoire, il faut savoir que très souvent ces patients ont un trismus, et quand on arrive à lever ce trismus, à intervenir, à couvrir la perte de substance, il est nécessaire d'avoir une équipe entraînée pour la physiothérapie. Dans le cas contraire, on peut assister à beaucoup de récidives, ce qui peut être donc assimilé à un échec par rapport à la prise en charge. Donc, il est impératif, et ça c'est un défi aussi majeur, d'avoir une équipe de physiothérapeutes derrière ou un personnel entraîné à la physiothérapie pour pouvoir faire une prise en charge post-opératoire adéquate en vue d'éviter ces récidives. Donc, tout cela constitue je pense, un certain nombre de défis majeurs liés à la prise en charge chirurgicale des séquelles de NoMA. Heureusement que de plus en plus, les équipes arrivent à comprendre et à réaliser des techniques assez élaborées de prise en charge, notamment donc pouvoir réaliser des lambeaux libres dans nos pays, puisqu'il faut savoir qu'auparavant, du fait de la complexité de ces prises en charge, les patients étaient systématiquement envoyés en Europe, notamment à l'hôpital universitaire de Genève. Beaucoup de nos patients et de nos compatriotes sont allés là-bas dans le cadre de leur prise en charge, ce qui peut être très contraignant du fait que j'avais dit déjà plus haut que la prise en charge peut nécessiter plusieurs interventions et être étalée dans le temps. Donc, vous comprendrez avec moi que le fait que les enfants restent plusieurs mois en Europe et reviennent après pour rejoindre leur village peut être problématique. Donc, actuellement, on peut, dans de très bonnes conditions chez nous, réaliser toutes ces interventions. Il faut savoir que les lambeaux libres actuellement, quand on compare, en tout cas, avec le recul que nous avons, nous pouvons dire qu'il n'y a pas plus de complications lorsque ce type d'intervention est réalisé que dans des interventions beaucoup plus simples. Donc voilà, en grande partie, ce que je peux dire par rapport aux défis que nous avons à relever dans le cadre de la prise en charge chirurgicale des séquelles de NoMA. Donc, tout en vous souhaitant une très bonne conférence, je vous réitère tous mes vœux tous mes meilleurs vœux pour ce nouvel an, en espérant que cette pandémie pourra être vaincue pour cette année et qu'on puisse se retrouver physiquement une très prochaine fois et discuter de la lutte contre ce qui constitue vraiment un fléau dans nos pays. Je vous remercie.
Hello, everybody. Bonjour tout le monde. Thank you very much for giving me this great opportunity to make presentation, and congratulations on MSF and the International Society for Neglected Tropical Disease, your leadership to organize this wonderful webinar. This is Yuka Makino. I'm a technical officer for oral health in the WHO Regional Office for Africa. Today, I make presentation from my office located in Brazzaville, Congo. I'd like to introduce what WHO and WHO Regional Office for Africa has conducted to fight against NoMA. Let me introduce our activity chronologically from 1994. 1994, WHO declared NoMA as a public health problem. In 1998, NoMA was identified as one of the priorities of the regional strategy for oral health in the WHO African region, 1999 to 2008. In 2001, to help bridge the knowledge gap on NoMA and improve early detection, diagnosis, and management of the case at especially the primary care level, WHO Regional Office for Africa established Regional Noma Control Programme. Overall goal of this program is sustainable elimination of NoMA as a public health problem in the African region. I'd like to briefly introduce what WHO do for the Regional Noma Control Programme. Advocacy. Advocating for increased political commitment at the higher levels to address NoMA issue. Provide technical and financial support to country to develop and implement the National Noma Control Programme. Third point is we build capacity of the focal point of the National Noma Control Programme in the Ministry of Health. We also develop and provide guidance, tool, and standards with the country to develop and implement National Noma Control Programme. Last but not least, we also support operational research to generate evidence for corrective action and continued learning on NoMA. 2007, WHO resolution urged NoMA-affected countries to implement National Noma Programme by integration into other program areas such as childhood illness, maternal child care, and reduction malnutrition and poverty program. In WHO African region, since 2013, Regional Noma Control Programme has been financially supported by Hilfaction NoMA, German NGO. Especially since 2013, as you see this map, we selected 10 priority countries to implement National Noma Control Programme. Today, I think we also have a representative of the priority countries, so we can listen their experience of the National Noma Control Programme. 2016, Regional Oral Health Strategy was adopted by country to take more integrated approach for oral health promotion, oral disease prevention and control, including NoMA as a part of non-communicable disease and universal health coverage. In the same year, our regional office published the Promoting Oral Health in Africa to provide the best practice for the prevention and management of oral diseases, including NOMA. In 2017, regional office information brochure for NOMA was published to help country to NOMA staging, such as acute necrotizing gingivitis stage, on-demand stage, ganglion stage, and scarring stage, and sickle stage. And we also provide the management guidance by each stage of the NOMA. Just recently, we published a step-by-step guide to develop national action plan for NOMA prevention and control in priority country to help country to develop the national action plan. So we'd like to utilize today's opportunity to introduce this guidance documents. As you know, we have a various challenge for NOMA prevention and control, but I just would like to summarize 5 challenges. First point is existence of broader determinants of NOMA. For example, NOMA is linked with complex interaction in immunocompromised children with measles, malaria, or HIV, malnutrition, lack of vaccination children, and poor oral hygiene, and also other social and environmental factors such as maternal malnutrition, and also cross-spacing of pregnancy actually associated with NOMA. Also, general population and health workers, they do not know about NOMA. Therefore, that one also delay the detection of NOMA. Other part is NOMA is generally not integrated into the routine surveillance system. So it is very difficult to know the epidemiological situation. The fourth part is NOMA is linked with social stigma. It is lead to hiding of affected children by their family, and also this make it difficult to integrate NOMA survivor and its family into the society. Then final point is we do not have enough evidence of the epidemiology, etiology, pathogenesis, treatment efficacy of NOMA yet. In order to solve these kind of challenges, in consultation with country and experts, we developed this step-by-step guide to support NOMA priority country to develop and implement National Noma Control Programme. We also provide specific objective to overcome the challenge which I raised before. First one is to enhance integration, coordination, and leadership of the National Noma Control Programme. Second point is strength and develop capacity at the primary care level for the identification, prevention, and treatment of early stage of NOMA. But not only the facility level, but maybe the NOMA children or affected population, their first entry point would be not facility level, but maybe community level, such as traditional healer or community health worker. Therefore, it is also important to strengthen and develop the capacity at the community level in oral health promotion and NOMA prevention. But we also need to improve the awareness among general population and policymakers. Therefore, we also undertake awareness raising and a social mobilization campaign to improve public knowledge about NOMA. And then the challenging of the surveillance, we definitely have to consider and overcome, including through decentralization, referral system, and integration of NOMA into existing surveillance would be really critical point. Then to contribute to the integration of NOMA survivor and their family into the society. And then final point is improve learning through monitoring, evaluation, and research. As mentioned that we developed this 7 specific objectives. Based on each specific objective, we also provide, this guidance also provide key activity and key indicator as well. This January, in 2021, WHO Executive Board discussed oral health agenda. This is first time since 2007. This discussion also includes NOMA issue and also discuss the importance of integration of Noma into other areas such as neglected tropical disease. We are still in the process, but definitely our effort is moving forward and we can create some momentum for fight against Noma. Let's keep this momentum and accelerate, eliminate Noma as a public health problem. Thank you very much for your kind attention. Merci beaucoup.
So we've now reached the end of this conference on Noma, a disease that shouldn't exist anymore, yet continues to devastate some of the world's most neglected communities. It's that kind of end, though, that's really only a beginning towards more recognition, towards more visibility, towards more partnerships. And so, if I may perhaps leave you with what I might call a bit of homework, if each and every one of us who felt compelled today, for whatever reason and from whichever background, to sign up and hear a little bit more about Noma throughout this conference, if each and every single one of us here could go away from this event and tell just one more person about Noma, or perhaps post one social media message. We say an image speaks louder than words, so please do consider to share the short film we saw at the start of the conference. It's available on YouTube and in 9 languages. Also, please do continue to follow the work of the NGOs and organizations already involved in the fight against Noma, whether Médecins Sans Frontières, the many organizations in the International NoNoma Federation, and many more. And also, please consult some of our very own resources on Noma here at the International Society for Neglected Tropical Diseases. As I'm speaking, many relevant links have just been posted in the chat box, in fact. However we go about it, we as a diverse community brought together today at this event are now on a journey to bring Noma once and for all out of neglect. The road ahead will be paved with success through partnership. And so in these final moments, I would like to renew our extreme gratitude for the contribution of all those who took part today. First and foremost, to all the Noma survivors who shared their most personal stories with us, to the speakers for their invaluable insights, the numerous advocates and organizations who have been working tirelessly for decades in the field, and you, the participants, for hearing these messages and calls to action and hopefully spreading the word far and wide. So until we meet again, we would like to wish you all the best, keep safe, and thank you once again for your time today to take Noma out of neglect.